So, mycobacterial infection is no doubt increasing in prevalence also, and it is challenging for the treatment and diagnosis also. So, as I already mentioned, there are more than 190 species are there of MOTT, and it is present everywhere, soil, water. So, it is very common in the environment, ubiquitous presence, and that leads to the infection. As already mentioned, according to the Runyon classification of MOTT, there are different types of slow growers and fast growers. Either it is grows within 7 days in the media, then it is fast growers, and Mycobacterium abscessus is very common for the infection, and slow growers is more than 7 days. Mycobacterium avium intracellular, MAC or Kansasi marinum are the examples for that. Runyon classifications are there, depends on scotochromosomes, photochromosome, but I think it is more for the microbiology point of view. At least આપણે તો એને સેમ્પલ આપી દેવાનું, આપણે કહેવાનું ભાઈ કયું ઓર્ગેનિઝમ છે. ઇન ડિટેલ આપણે બહુ જવાની જરૂર નથી. If we see epidemiology, definitely increasing in prevalence, particularly in Asia and in India. If you see in the world, only 1 cases per 1 lakh, but in India it increased from 1 to 28 per lakh. Most of the MOTTs are present in the pulmonary, 94%, 3% in lymph node, and 3% in soft tissues. If you see organism-wise, 70% are MAC, Mycobacterium fortuitum is around 5%, and Kansasi is only 3%. Where it is commonly occur? તમારા કયા પેશન્ટ્સમાં MOTT થાય? ખાસ કરીને સ્ટ્રક્ચરલ લંગ ડિઝીઝ જેમ કે બ્રોન્કિએક્ટેસિસ છે, COPD છે, સિસ્ટિક ફાઇબ્રોસિસ તો ચલો આપણે અહીંયા બહુ નથી, પણ એટલીસ્ટ બ્રોન્કિએક્ટેસિસ અને COPD પેશન્ટ્સ અથવા ઇમ્યુનો કોમ્પ્રોમાઇઝ પેશન્ટ છે એની અંદર પલ્મોનરી non-tuberculous infections are very common. 33% COPD cases, 28% bronchiectasis, and 11% GERD or respiration. Particularly old age population વધતી જાય છે અને this disease is more common in old age. તો પાર્કિન્સોનિઝમના પેશન્ટ્સ કે જે લોકોને કફ રિફ્લેક્સ અથવા તો પ્રોટેક્ટ નથી કરી શકતા એરવે, એ લોકોને એસ્પિરેશન થાય, and there are many times atypical mycobacteria are common in that group of patients. Environmental source, everywhere it is present, but particularly soil and water, it is more isolated. There is one hypothesis why these cases are increased, અને મને થોડુંક ફની લાગે છે, એ કહે છે કે increased use of showers rather than bath, that may also leads to increase the prevalence of atypical mycobacterial infection. So how it presents? Most of the atypical mycobacterial presents in the pulmonary at, I said, 93%, sometimes in lymph nodes, cutaneous, and particularly HIV patients or immunocompromised patients, disseminated infections are common. In community acquired, either immunocompromised or immunocompetent patients, but this is important healthcare associated, particularly in wounds, after giving even injections. If there is no aseptic precautions, then fast grower infections, atypical infection at site of IM injections are also seen. So we have to thoroughly clean our devices like bronchoscope, gastroscope, because many times that water can also infect the scope, and that leads to the infection to the patients. Dialysis equipment, particularly previously when there is peritoneal dialysis, then very high chances of peritoneal infection with the atypical mycobacteria are seen. And nowadays, as I mentioned, particularly gynecologists, જે લોકો અથવા તો લેપ્રોસ્કોપિક સર્જન ફોર્માલ્ડિહાઇડની ચેમ્બરમાં આપણે પહેલાં જોયું હોય તો સ્કોપ રાખતા હતા, બટ સ્ટ્રિક્ટલી એ પ્રેક્ટિસ બંધ કરવી જોઈએ, કારણ કે સો મેની કેસીસ ઓફ એટિપિકલ માઇકોબેક્ટેરિયલ ઇન્ફેક્શન એટ ધ વુન્ડ સાઇટ, અને વુન્ડ હીલ જ ના થાય. સો વી હેવ ટુ ટેક કેર ઓફ ધેટ પાર્ટ ઓલ્સો એઝ અ ડૉક્ટર. ઇન ઇમ્યુનોકોમ્પ્રોમાઇઝ પેશન્ટ્સ, particularly HIV, 1982-84ની આસપાસ પેન્ડેમિક HIVનું ચાલુ થયેલું શરૂઆતમાં. At that time when there is CD4 count is less than 50, because there at that time there is no ARTs present, and mostly 90% of MAC infections are seen, and prognosis is also very poor in that type of immunocompromised patient. Catheter related infections, Mycobacterium fortuitum is seen, peritoneal shunt infections, and particularly nowadays when there is increased number of transplant patients, kidneys, lung, આપણે ભાઈ આવેલા છે સ્પેશિયલ અમદાવાદથી, we discuss about the lung transplant also. So in that type of cases also there is a atypical mycobacterial infections are seen. Now the question, person to person transmission is possible or not? Tuberculosis માં તો definitely છે. But in atypical mycobacterial infections, till date, routinely there is no person to person transmission. But only in cases of cystic fibrosis, only 2 series are seen where few of the genes are seen. પછી તો કરે ને કે ભાઈ ઇન્ફેક્શન બીજામાં લાગ્યું છે તો એમાંય જીનોમ સેમ છે તો જ એનું ક્રોસ ઇન્ફેક્શન છે, અધરવાઇઝ તો એને બહારથી પણ લાગેલું હોઈ શકે. So there is only 2 series where cystic fibrosis patient there is a person to person transmission is seen, but otherwise there is no person to person transmission is till date seen. Now diagnosis. કોઈ પણ પેશન્ટ આપણી પાસે આવે તો આપણે ફર્સ્ટ ઓફ ઓલ ક્લિનિકલ, then added with the laboratory test, radiological test, right? So for atypical mycobacterial infection, clinical presentation is almost same like tuberculosis. Fatigue, night sweat, low grade fever, weakness. But when you suspect tuberculosis or atypical infections, you go for the X-ray or in some centers with the CT scan. So in radiologically, if there is a nodular or cavitary opacities, thin wall cavitary opacities are seen in chest X-ray, or in HRCT, bronchiectasis or multiple small nodules are seen, then definitely you have to suspect about the atypical mycobacteria. પણ આપણે atypical mycobacteria suspect કરીએ એ પહેલાં definitely આપણે tuberculosis તો suspect કરીએ જ છીએ. So you send the good quality early morning in fresh container, sterile container, sputum, because this is ubiquitous. એટલે ઘણી વખત એવું બને કે કન્ટેનરમાં જ ઓલરેડી એટિપિકલ માઇક્રોબેક્ટેરિયા હોય અને એમાં તમે સ્પુટમ આપો અને એ સ્પુટમ જાય અને એમાં તમને એફ બી પોઝિટિવ આવે. પણ સાઇમલ્ટેનિયસલી એઝ મેડમ સેડ્સ કે જીન એક્સપર્ટ પણ સ્પુટમની સાથે થતું જ હોય છે, એન્ડ જીન એક્સપર્ટ ઇઝ નેગેટિવ, દેન યુ હેવ ટુ સસ્પેક્ટ અબાઉટ ધ atypical mycobacteria. So these are the few HRCT scans where you can see in the right side there is a middle lobe bronchiectasis is there. On the left side, small nodules or tree in bud appearance type of pictures are seen in left lower zone with thick walled cavity, and on right side there is a thin walled cavities are seen. These are the few presentations in HRCT of atypical mycobacteria. Now important is microbiology. Culture. Not only one culture, but at least 2 cultures. These are the slides from the ITSA guideline of 2020, particularly international guidelines who gives this all the information. Over here in microbiology point of view, positive culture results from at least 2 separate expectorated sputum sample. Positive culture results from at least 1 bronchial wash or lavage. If there is no sputum, then you have to go for the bronchoscopy, and only 1 positive culture is positive, then it is positive for atypical mycobacterial, and sometimes you need transbronchial biopsy, and if it is positive, then it is positive. There are the few tests in chronicle order. First of all, sputum microscopy, then CBNet, then sometimes required culture, either liquid, bactec or solid media, LJ media, and then species identification from genomic structures. This is a flow chart. Thanks to my microbiology friend Nishit Milan Karsandia. He gives the chart, especially when you suspect case of tuberculosis, either it is mycobacterial or MOTT, then go for Jayesh. If Jayesh is positive or negative, simultaneously go for the gene expert. Jayesh is positive and gene expert is positive, it is Mycobacterium tuberculosis. Jayesh is negative, but gene expert is positive, then maybe it is Mycobacterium tuberculosis. But gene expert is negative, then go for the TB culture, probable because it is MOTT or atypical mycobacteria. In MGIT tube liquid culture media, if there is a growth, then with serologic art test, you can see for the Mycobacterium tuberculosis or MOTT, and you can see the put the drug panel to identify the drug sensitivity, and to identify the with the help of MALDI-TOF you can identify the species also. Basically નીચેનો જે બધો ભાગ છે ને એ માઇક્રોબાયોલોજી વાળાને જોવાનો છે. આપણે અડધે સુધી જોવાનું છે કે ભાઈ સ્પુટમ સીબીનેટ, સ્પુટમ પોઝિટિવ છે, સીબીનેટ નેગેટિવ છે, then go for the atypical. Bakinu structure. But definitely why this is important? Because organism, its clinical presentation, its severity of the disease, on a drug sensitivity point of view, which type of regimen you have to choose is very important. So lower part is also important. As radiography point of view in X-ray, most of the time thin walled cavity or little consolidation is seen, and reticular or nodular presentation is there. In bronchiectasis, most of the time MAC is present. In COPD is many times, in particular in our country, COPD patients, old age patients, smokers, and many times in past there is some structural lung disease. So in COPD also atypical mycobacteria is very common. 30% of the patients with cystic fibrosis in USA is also presented with atypical mycobacteria infections, and MAC is again #1 organism in that disease group of patients also. Most common MAC means Mycobacterium avium intracellular complex, and MAC bacteria are common in environment, cause infections by inhaled or swallowed, and that's why many times presentation along with respiratory symptoms, there is diarrhea and abdominal pain also. In that type of patients, in a laboratory test, if you see for the CBC, many times anemia and neutropenia is seen. Presentation, mostly pulmonary MAC infection in immunocompetent host only, but disseminated MAC is present in very advanced AIDS where CD4 count is less than 50. Immunocompetent patients, COPD patients, smoker, old age, then many times in old age lady, thin elderly woman, non-smoker, no previous lung disease, and many times it is called as Lady Windermer's syndrome also. This is presentation of atypical mycobacteria, and presentation in Lady Windermer's syndrome is thin body habitus, pectus excavatum, MVP may be present, kyphoscoliosis may be present, joint hypermobility, and right middle lobe or lingula, right side ma middle lobe, left side ma lingular lobe are most commonly involved, and cylindrical bronchiectasis is seen. So this is all diagnosis. Now what is the management? Again, it is differ from the routine TB patient, Mycobacterium tuberculosis patient. As madam has very well explained about basic first regimen HRZD, then if H is resistant, then with the help of linezolid or fluoroquinolones, you can replace. Multi-drug resistant, rifampicin resistant is there, then what is the guidelines? Pre-XDR or XDR, then what is the guidelines? But over here, regimen is selected from the organism, #1. #2, drug sensitivity. Most of the time macrolides, આપણે ફર્સ્ટ માઇકોબેક્ટેરિયમ ટ્યુબરક્લોસિસમાં જોઈએ તો ક્યાંય મેક્રોલાઇટ્સનો ઉલ્લેખ જ નથી. But over here, macrolides is very important for regimen. Sometimes fluoroquinolones or aminoglycosides, amikacin is also important. This is all depends on the severity of the disease. If patient has in radiology only nodular pattern, then it is not very severe. But there is a cavitary diseases, then disease is severe. If macrolide resistant or sensitive, if rifampicin is resistant or sensitive, if aminoglycoside sensitive or resistant, on that basis you have to choose the treatment. Most common organism is MAC, and for MAC, if macrolide susceptible, then either you have to make a regimen with RE, rifampicin 600 milligram, ethambutol around 1000 to 1200 milligram, depends on the weight of the patient, and you have to add azithromycin or clarithromycin. According to the guidelines, they prefer azithromycin over the clarithromycin, because in clarithromycin you have to give 2 times a day and cost is also high, so they prefer azithromycin over clarithromycin. Most of the time it is daily regimen, but if patient is not tolerate very well, then you can go for the 3 times in a week also. Another one organism is Kansasi. From tap water, pulmonary disease is more commonly seen, and many times cervical lymphadenopathy or cutaneous involvement is also seen. Particularly in organ transplant or AIDS, it is more common. Silicosis patient is also very common, hairy cell leukemia, or in transplant patients it is seen, and many times presentation with cavitary in Kansas. These are the HRCT pictures from the guidelines. Treatment, again rifampicin and ethambutol. અહીંયા ક્યાંય pyrazinamide છે જ નહીં, એટલે ભૂલી જજો pyrazinamide ને. Rifampicin 600 milligram daily, empty stomach. Ethambutol again 1000 to 1200 milligram per day. And over here in Kansas, you have to add isoniazid 300 milligram daily, or macrolide in the form of azithromycin or clarithromycin. For duration is at least 12 months of this disease, and particularly 12 months after culture conversion. So આપણ ત્યાં કલ્ચર ક્યારે ક્યારે મોકલવાના? એટલીસ્ટ 3 months આપણે સ્પુટમ ફરીથી કરવું જોઈએ, સીબીનેટ કરવું જોઈએ, અને at 6 months we have to do the culture again. Xenopy, spelling mistake છે, sorry. Mycobacterium xenopy, it's a slow growing scotochromosomic lesions found in first time in one of the frog of the Africa, and from that this name is there, Mycobacterium xenopy, and it is spread through the hot water supply of hospital systems many times seen. Treatment, again rifampicin and ethambutol is there, macrolide and or moxifloxacin or fluoroquinolones, either of the fluoroquinolones, moxifloxacin or levofloxacin. And sometimes patient does not respond, then you have to add parental amikacin for at least 3 to 4 months. Initial, all these three are slow growers. Now rapid growing Mycobacteria, Mycobacterium abscessus is there, particularly in chronic lung disease or post-traumatic wound infections. These organisms are seen. And again, macrolide-based multi-drug regimens, and sometimes surgical excision. If there is a significant hemoptysis is there in the lung, large cavity, hemoptysis is not controlled, then that lobe should be removed from the patient, and you can manage with the macrolides. Duration, again after culture conversion for at least 12 months. Results many times are not good. Only in 60 to 70% of the patients treatment is successful, and recurrence rate is very high. Few new medicines in the form of interferon gamma or linezolid or newer fluoroquinolones are in pipeline, but there is no enough data for that. Thank you very much.